and Geriatrics in the Division of Medicine and Dentistry at the Health Resources and Services Administration. And on behalf of HRSA and the Division of Medicine and Dentistry, I want to welcome you to this special session of Grand Rounds entitled Preventive Medicine Grand Rounds, Screening and Referral to Evidence-Based Eating Disorder Treatment in Primary Care. I want to thank those who made this webinar happen, those at HRSA, Dr. Irene Sandvold and Nancy Douglas Casilius, and Dr. Sabrina Madoff from the Office of Women's Health. Our colleagues and partners over at SAMHSA, Umberto Cavallo, and Captain Antonio Neri, and also those from the Centers of Disease Control and Prevention, and Dr. Christine Peet from the National Center for Eating Disorders at the University of North Carolina, Chapel Hill, and Dr. Louise Metz from the Mosaic Comprehensive Care. So why is this topic so important? Well, the 21st Century Cures Act, enacted in December 2016, put into legislation and included provisions related to eating disorders that provided increased access to eating disorder treatment and coverage through the clarification of the mental health parity, facilitation for identification of model programs and materials for educating and training health providers, including coordinating training for health professionals for the early identification of disorders. And finally, providing eating disorder prevention, intervention, and treatment information to be available for public awareness. And just to let you know, this information is included on the Health and Human Services Office of Women's Health website. We want to reach out to educate programs and those in practice, particularly in primary care systems, on how to identify, access, and manage these conditions, assess and manage these conditions. This presentation illustrates that preventive medicine residency and fellowship training focus on applying systems-based approaches to ensure quality of population health services. Our presenters today will provide us with information on the prevalence, detection, and screening of these disorders. And again, we want to thank you for being here. And I'd like to turn this over to our partner over at SAMHSA, Umberto Cavallo.
Thank you very much. Good afternoon, everybody. Thank you all for being here today. Like I said, my name is Umberto Carvalho, and I'm the SAMHSA project officer in charge of the cooperative agreement that we have with North Carolina, Chapel Hill, for the National Center of Excellence for Eating Disorders. In case you don't know, SAMHSA is actually the agency within the U.S. Department of Health and Human Services that leads public health efforts to advance the behavioral health of the nation. Our mission is pretty much to reduce the impact of substance abuse and mental illness in our country and communities. So as you all know, eating disorders are real and complex medical and psychiatric illness that can have serious consequences for health, productivity, and relationships. Based on the latest statistics, we have pretty much over 30 million people of all ages and genders suffering from eating disorders. Also, eating disorder is not a group-specific condition, and it affects actually pretty much every race, ethnicity, and it has one of the highest mortality rates of any mental illness. So SAMHSA takes mental illness very seriously, and that's why we funded this Center of Excellence. So the purpose of the Center of Excellence is, the purpose of this program is to develop and disseminate training and technical assistance for healthcare practitioners, but also for the public on issues related to addressing eating disorders. So Dr. Christine Peet is the director of this program of the Center of Excellence for Eating Disorders, and she's going to be discussing, and she's going to be talking a little more about the center, and she's going to be discussing this very important subject. So I would like to thank you all for being here today and bringing the next speaker. Thank you all.
Hello, everybody. Good morning, good afternoon. My name is Dr. Sabrina Madoff, and I'm the Director of the Office of Women's Health here at the Health Resources and Services Administration Office of Women's Health. My office is very pleased to be partnering with our colleagues in the HRSA Bureau of Health Workforce, the Centers for Disease Control and Prevention, and the Substance Abuse and Mental Health Services to put this webinar on for you. We're also extremely pleased to be partnering with Dr. Christine Metz and Dr. Christine Pete and Dr. Louise Metz, who are our guest speakers this afternoon. I think you're really going to enjoy and learn a lot from their talk this afternoon. As many of you know, HRSA supports more than 90 programs that provide health care to people who are geographically isolated, economically or medically challenged, and we do this work through a series of grants and cooperative agreements to more than 3,000 awardees. Many of these grantees work at the community level, at colleges, at health centers, and at other community-based organizations. We serve over tens of millions of people every year, and this particular topic is of increasing importance as we look at the integration of behavioral health in primary care. Our work in the Office of Women's Health is very important to HRSA. We provide support and leadership to HRSA programs by integrating evidence-based women's health-related policy and programs across all of HRSA's bureaus and offices, and we support the health, wellness, and safety of women and girls across the lifespan. As you heard from my colleagues, eating disorders are serious behavioral health conditions, but there are many things we can do as public health professionals, as clinicians, and as caring friends, family members, and partners to help those who are suffering from these conditions. So with that, I welcome you again to this very, very exciting webinar, and I'd like to introduce our speakers for this afternoon. First, we have Dr. Christine Pete. Dr. Pete is the director of the National Center for Excellence in Eating Disorders and an assistant professor of psychiatry at the University of North Carolina at Chapel Hill. She has completed her undergraduate training in psychology at the University of Arizona and has master's degrees and doctorates in clinical psychology from the University of North Dakota. She also went on and did an internship at West Virginia University, after which she went on to complete her postdoctoral fellowship in eating disorders research at the University of North Carolina. As a licensed clinical psychologist, Dr. Pete's program of research has focused on innovative psychological treatments for eating disorders, treatment dissemination, and examining the comorbidity between eating and weight pathology and medical morbidity. Dr. Pete also continues to serve as a member of a multidisciplinary team treating eating pathology at the UN Center of Excellence for Eating Disorders, and she also conducts pre-surgical evaluations for bariatric patients in the UNC Bariatric Surgery Program. She also serves as a supervisor for predoctoral psychology trainees and psychiatry residents receiving psychotherapy training. So welcome to Dr. Pete. We also have Dr. Louise Metz, who is the owner and founder of Mosaic Comprehensive Care. Dr. Metz is an internal medicine physician and an expert in eating disorders and gender-related health care. She is the owner and founder of Mosaic Comprehensive Care, and her background includes an undergraduate degree in biology and women's studies at Duke University. She also attended medical school at the University of North Carolina, where she was a member of the Alpha Omega Alpha Medical Honor Society. Dr. Metz was inspired to create Mosaic with a unique medical model focusing on individualized and collaborative care in a welcoming and non-judgmental environment. In this setting, she provides comprehensive primary care, including preventive medicine and management of chronic medical conditions. Dr. Metz also has expertise and clinical interest in eating disorders, menopausal care, transgender health, irritable bowel syndrome, and management of depression and anxiety. She offers a very patient-centered approach to medical care and provides multidisciplinary care for her patients by closely working with other providers. She's passionate about providing a health at every size approach, using other non-diet approaches to health for all, and it's her goal and it's her clinical goal to help change the paradigm surrounding the way we all address weight and health in the medical setting. So with that, I will turn it over to our special guest speakers this afternoon, Dr. Christine Pete and Dr. Louise Metz. Thank you.
Thanks so much, everyone, for those introductory comments. I just wanted to take a brief moment to introduce myself. I'm Dr. Christine Peet, the director of the National Center of Excellence for Eating Disorders. And today, Dr. Metz and I will be giving you an overview of eating disorders and how you might manage them in a primary care setting. But prior to doing that, we were hoping to get a general sense of who all might be on the call. So at this time, I'd like to have Lillian bring up the first polling question. And what we're going to do is simply ask about the the setting in which you practice. So we recognize that there are a number of people on this webinar, and there might be several different practices that are represented here. So if you would just simply choose the appropriate setting using the radio buttons there on question 1, this will give us a general sense of who all is attending the webinar this afternoon or this morning, depending on where you are. I see some of the responses starting to trickle in. I'll give everyone just a little bit of time here to respond. And it looks like as I'm taking a look here at the responses, we have folks from a variety of different disciplines. Great. I'm going to give everyone just another second to respond, and then we'll move on to the second question. Okay, great. Lillian, if you'd go ahead and move on to the second question for us, that gives us a nice general sense of who all is represented on the call. Our second question in terms of getting to know you all is getting a sense of what your clinical background is. So you might be practicing in primary care or a mental health setting, but what is your particular role within that setting? So are you a physician? Are you a nurse? Again, here, just choose the appropriate radio button to give us a sense of who all is on the call. As you can see, these responses are starting to trickle in. It looks like we've got folks who are representing a variety of different disciplines from nursing, medicine, social work. This is great. And again, I'm just going to give everyone another second or two here to respond to the appropriate radio buttons. This is great. All right, so you can see that there's a variety of different disciplines in terms of the practice setting and also a variety of different roles across those settings. And I think this is really great because the information that Dr. Metz and I will walk you through today is going to be applicable regardless of the type of setting that you're in. There's going to be a primary focus on primary care, but I think there's a lot of lessons to be learned irrespective of your discipline or your setting. So Lillian, if I can have you take the polling question away, we'll go ahead and get started now for the bulk of the presentation. Thanks so much, everyone, for responding. So before I kind of jump into the heart of the presentation, I wanted to give everyone an overview on what exactly the National Center of Excellence for Eating Disorders is. Some of you may not be familiar with our program yet, and that's perfectly fine. But we were established in the fall of 2018 through SAMHSA to essentially be the living, breathing embodiment of a portion of that 21st Century Cures Act that was referenced early in the presentation. Right now, our primary focus is on educating and training both healthcare professionals and the public on the identification and management of eating disorders. So essentially, we'd like to serve as the centralized hub for all information on eating disorders, whether you're a family member or a loved one, or whether you're a healthcare professional trying to figure out how you manage these conditions in your practice. Right now, our web-based platform is in development. So what we have available at our current website is kind of a limited version of what will be there down the road. Down the road, we're going to have lots of interactive trainings where you can get different skill sets, where you can access different kinds of information, treatment guidelines, all kinds of pocket guides, things that will be useful for you in your clinical practice or as a loved one. And the advantage of it being web-based is that you will have access to the same types and levels of trainings, whether you are in a rural setting or you happen to be in a major metro center. So we're really trying to make sure that everyone has access to this information. So if you'd like to learn more about us and sign up for our updates so you can hear more about our developments as our center continues to grow, please go to the web link that you can see here at the bottom of the screen. Sign up for ongoing updates, click around our site to learn more about us, and feel free to shoot us questions with any information that you'd like to have. In terms of kind of getting us started for this afternoon's presentation, I thought I might spend some time kind of unpacking what we know to be true about eating disorders. The reality is that there's a lot of myth out there when it comes to eating disorders, their diagnosis, what treatment looks like. But several years ago, the Academy for Eating Disorders worked with Cynthia Bulick, who is the founding director here at UNC, to develop 9 truths about eating disorders so that people could actually know the facts about these conditions. So the first truth is that eating disorders occur in people who may look healthy, yet may be extremely ill. And this first truth was really designed to highlight the idea that you cannot tell who has an eating disorder simply by looking at them. The second truth is that families are not to blame and can actually be the patient and provider's best allies in treatment. So many years ago, there was a paradigm in which we would blame families for eating disorders, or we assumed that the eating disorder arose from some kind of family dysfunction. But we've learned over the years with research and with treatment that families are not to blame and that actually they can be a crucial component of treatment. Truth number 3 is that an eating disorder is a diagnosis that disrupts personal and family functioning. So this isn't something that is just contained to the individual, but can have negative ramifications across the social circle. We also know that with truth 4, eating disorders are not choices, but are serious biologically influenced illnesses. I think there's a lot of myth out there still that eating disorders are something that people choose to do because they're vain or they're bored or they're seeking attention, and that really undermines the seriousness of these biologically influenced illnesses. Truth 5, we know that eating disorders do not discriminate, period, full stop. It does not matter if you are male, female, or a sexual or gender minority. It doesn't matter your age, your race, or your socioeconomic status. Eating disorders can affect anyone. Truth 6, eating disorders carry an increased risk for suicide and also medical complications. And this truth, although a sobering one, is one that's designed to highlight this idea that these are serious illnesses and that they carry with them significant risk of both suicide and various medical complications that Dr. Metz will talk a little bit more about further along in our presentation. We also know that with Truth 7, genes and environment play important roles in the development of eating disorders. There tends to be a complex interplay between these two things, and there is no single path to an eating disorder. Mirroring that is Truth 8, where genes alone do not predict who will develop eating disorders. So although in recent years we've learned a lot more about the genetic components associated with eating disorders, we know that genes alone are not going to determine whether or not you will develop this condition. And finally, Truth 9, full recovery for an eating disorder is possible. And this is something we think is so important that everyone here is aware of, that these are conditions that, while they can be chronic in nature, can absolutely be treated to full recovery. And early detection and intervention are a crucial component of that, which is part of why we think it's so important that a primary care audience or even a general mental health care audience is aware of some of what we're going to talk about today. So with that in mind, I'd like to identify the 3 different goals that we have for today's presentation. So the first is to simply get familiar with those DSM-5 eating disorder diagnoses. What are they according to the current nosology? Secondly, we'll talk a little bit about screening measures and ways to identify these eating disorders in your practice. And then lastly, Dr. Metz will spend some time talking about how you actually manage these within a primary care setting. So with regard to this first goal, I'd like to talk first a little bit about anorexia nervosa. Anorexia nervosa is a diagnosis that many of you in here are probably familiar with. And essentially, its defining feature is an intense fear of gaining weight or becoming quote unquote fat and restricting your energy intake or your caloric intake such that you get to a significantly low body weight. Now, According to the DSM-5 nosology, there are two different subtypes. So there's someone that might be purely restricting or limiting their food intake, or someone might be engaging in regular binge purge cycles. And we'll talk a little bit about what that means later on. But essentially, this is a diagnosis that is characterized by this intense fear of weight gain to the point that someone is purposefully restricting their food intake in order to lose that weight. There are severity ratings according to the DSM-5 nosology, ranging from mild to extreme, depending on the BMI of that particular individual. I won't belabor those points verbally, as you can see these here on the slides. But one thing to note about anorexia nervosa is that the prevalence is roughly around 1% of the general population. Now keep in mind that when I'm talking about these prevalence estimates, I'm identifying the percentage of individuals that are manifesting full threshold symptoms. So someone is meeting every single diagnostic criterion. It's important to note this because these estimates are not going to take into account people that have subthreshold diagnoses or might have symptoms along that eating disorder spectrum, because of course these symptoms do occur along a spectrum and are not simply black or white, yes or no, go or no-go categories. With respect to the sex ratio, we know that anorexia nervosa is anywhere between 1.75 and 3 times more prevalent in females than males. And we know that anorexia nervosa, this diagnosis in particular, has the second highest mortality rate of any psychiatric illness, second only to opioid use disorder. Before moving into talking about the next couple of diagnoses, I wanted to spend some time unpacking what a binge eating episode actually is, because the next two diagnoses I'm going to talk about really are centered around binge eating episodes. So according to DSM-5 nosology, a binge eating episode is defined as eating an unusually large amount of food in a discrete period of time. So unlike people who might be grazing all throughout the day, a binge eating episode really is occurring in a short period of time, usually 2 hours or less. And more importantly, during this eating episode, someone is experiencing a sense of loss of control over either what they eat or how much is eaten. And this really is the hallmark criterion for a binge eating episode. It's not so much how much is eaten as this sense of being out of control. I simply cannot stop myself from eating even if I wanted to. And that's what would constitute an objective binge eating episode. During a binge eating episode, individuals also tend to endorse at least 3 of the following, again, to meet full threshold diagnostic criteria. Typically what we hear from folks is that during a binge, they will eat faster than usual, they eat to the point of feeling very uncomfortably full, and that disgust, shame, guilt, or depression that happens after a binge is almost palpable for most individuals who experience these kinds of eating episodes. So with that in mind, I'd like to talk now about bulimia nervosa. Now, bulimia nervosa is a diagnosis in which individuals experience these binge eating episodes that we just talked about, in addition to recurrent, regular, inappropriate compensatory behaviors. Now, what do we mean by inappropriate compensatory behavior? Well, essentially, these are going to be things like self-induced vomiting, laxative abuse, diuretic abuse, excessive exercise, fasting, all of the things that are kind of stereotypical when you think about bulimia nervosa. So essentially, individuals are engaging in these binge eating episodes and then using some type of inappropriate compensatory behavior to kind of get rid of or compensate for the food that they've eaten. Here too, there are severity ratings, but this time it's based on the number of inappropriate compensatory behaviors per week. Again, as outlined here on this slide, mild through extreme. In terms of prevalence, we know that bulimia nervosa occurs in roughly 1 to 2% of the general population. Again, this is just with respect to full threshold criteria. We also know that just like anorexia nervosa, this tends to be more prevalent in females. And the point I'm making here at the bottom about BMI is that bulimia nervosa is a condition which has a greater prevalence of BMIs greater than 25 in comparison with those with 0 eating disorder history. And I'm mostly highlighting this to underscore one of the truths that we talked about before, in the first truth actually, this idea that we can't know who has an eating disorder just based on looking at them. So you might think that you have an average or typical patient in your office, but that person may be struggling with bulimia nervosa, and you can't determine that based on BMI alone, given the breakdown that we have here. In a similar vein, binge eating disorder is a diagnosis that is defined by these recurrent binge eating episodes. But in contrast to bulimia nervosa, there is no engagement in regular inappropriate compensatory behaviors. So essentially, with this diagnosis, individuals are engaging in these recurrent, repetitive binge eating episodes, sometimes several times a day. The severity ratings here are based on the number of binges per week, again, ranging from mild to extreme, as you can see on this slide. In terms of prevalence, we know that binge eating disorder is actually the most common eating disorder diagnosis of these three. It occurs in roughly 3 to 5% of the general population, only for those meeting full threshold criteria. The estimates for those reaching sub-threshold criteria or somewhere along that eating pathology spectrum are much higher, of course. One of the things I thought important to note is that sub-threshold binge eating disorder, so not meeting every single diagnostic criteria, is more prevalent in men than it is in women. So again, if we're just going based on stereotypes of eating disorders, if you're only screening women, for example, or only suspecting that women have eating disorders, you're missing really crucial components of your patient population, missing really important screening opportunities. One of the other things we think it's important to note about binge eating disorder is that although there are not regular engagement in inappropriate compensatory behaviors, individuals with this condition may still be engaging in periods of dietary restriction. So commonly what we'll hear from folks is that they'll have several weeks, several days at a time where they just have binge eating episode after binge eating episode, but then they might go on some kind of crash diet or a really extensive period of fasting where they don't eat anything at all. It's not as temporally related as in bulimia nervosa, where there might be a binge immediately followed by some kind of inappropriate compensatory behavior. Sometimes this is more temporally spread out within binge eating disorder. But we think this is an important note, just so that, again, you're kind of getting a sense of the qualitative characteristics of these disorders. And again, here too, we can't simply assume that someone does or does not have binge eating disorder simply based on their BMI. There are many individuals that have BMIs that are not in the obese or even overweight range that may in fact be struggling with binge eating disorder. So it's important to think about screening holistically. Another eating disorder diagnosis that I'd like to take a few moments to describe is what's called avoidant or restrictive feeding intake disorder. And essentially, this is a diagnosis that is characterized by an eating or feeding disturbance where someone just simply doesn't get in enough nutritional or energy components throughout their day. Now, you might be thinking that this sounds pretty familiar to anorexia nervosa, and in some ways, the physical characteristics might present very similarly. So individuals with ARFID might be at a low weight, they might be malnourished, but these individuals don't have that same fear of gaining weight or that strong desire to lose weight, so that they're not necessarily purposefully trying to restrict their caloric intake or trying to restrict their energy intake. Many times these individuals simply aren't getting enough nutrition in because they have difficulties with the sensory characteristics of food, or they might just not prioritize eating in a way that actually has negative consequences on their weight. So these people might be relying wholly on supplemental nutrition, on feeding tubes. These individuals, though, cognitively don't have that same drive to lose weight or that fear of gaining weight that many individuals do with anorexia nervosa. One important thing to note here is that ARFID is something that we used to see a lot more in pediatric clinics or adolescent clinics, but we're seeing now that ARFID is something that can affect individuals across the lifespan. So it's important to think about screening for this condition, not just in pediatric populations, but in adults as well. And lastly, I'd like to touch briefly on our sort of catch-all diagnosis category that we refer to as other specified feeding or eating disorder. So for all intents and purposes, these are going to be individuals who don't meet every single diagnostic criterion for anorexia nervosa, bulimia nervosa, or binge eating disorder. One diagnosis that we'd like to highlight, though, is atypical anorexia nervosa. These are individuals who may be engaging in every single one of the diagnostic criteria for anorexia nervosa. So they're restricting their intake, they are just terrified by a fear of gaining weight, they don't want to change their body weight or shape in any way, they might be exceedingly malnourished, they might have cognitive difficulties because of this malnourishment, but their weight might remain in a quote-unquote normal place, or they may be even living in larger bodies. And many times these individuals are not screened for anorexia nervosa because they don't, quote unquote, fit the stereotype. So it's important to note that these individuals might be just as severely medically compromised or malnourished, but may not present in the same physical way that those with threshold anorexia nervosa do. The other two diagnoses to highlight are purging disorder and night eating syndrome. Purging disorder is a diagnosis that is characterized by regular self-induced vomiting in the absence of binge eating episodes. And night eating syndrome is a condition in which individuals are eating the majority of their calories late in the evening and experiencing a lack of appetite in the morning and throughout the early part of the day. So this isn't simply individuals that come home from work and eat a big dinner and have snacks before bed. This is really a clear lack of appetite in the morning and a drive to eat the majority of calories into the evening hours. So we've talked a little bit about what the diagnostic criteria are, and I recognize that these are pretty abstract concepts. These are pretty loosely defined constructs. So what I'd like to do is talk a little bit more about the warning signs and symptoms that you might actually see in your clinical practice. So what might your patients be talking about? What might you see or hear in conversations that you have? So first warning sign and symptom might be a preoccupation with food, eating, or calories. So stereotypically, this might be individuals who talk a lot about cooking or baking, but they never eat anything that they make. These might be people that just love watching, food TV or cooking shows, but never really seem to eat anything that they might make or have much of an appetite. There's also a reluctance to eat with others. So individuals might frequently say, I've already eaten, I'm not going to eat with you all today, or maybe they stop going to some of the regular meal outings that have typically taken place. Another warning sign or symptom might be food rituals. So sometimes people with eating disorders will cut food into really small pieces and kind of push that around the plate. They might use an excessive amount of condiments instead of eating actual food. They may also engage in things like eating in secret. So you might find evidence of food missing in the home, or maybe there's wrappers in the car or in the bedroom, such that somebody's been kind of sneak eating. In terms of inappropriate compensatory behaviors, self-induced vomiting might be suspected if someone regularly uses the bathroom shortly after eating. Excessive or rigid exercise might be characterized by, missing really important events just to exercise, being late to work or school or appointments because you just had to finish up that exercise routine, or maybe even exercising when you're injured. These would all be warning signs that something with someone's relationship with exercise could be off. Also, there might be weight and shape concerns manifesting as warning signs and symptoms. Things like frequent self-weighing. We hear from our patients that they're weighing themselves 2, 3, 4, 5 times a day. Maybe someone's wearing baggy clothes to hide their shape, or there's this constant scrutinizing of the body or shape in the mirror. Maybe they're pinching themselves as they're looking at different angles. These all might be specific warning signs or symptoms that come out during a clinical presentation or discussion. So with that in mind, if we're kind of thinking collectively, okay, we have these diagnostic criteria, we have these different warning signs and symptoms, what might an eating disorder look like if it's presenting in one of my patients in my practice? So the first point that we'd like to make is that, as we mentioned with the very first truth, eating disorder stereotypes are misleading. If we simply go by what the popular media or what social media has us believing about eating disorders, we're going to miss really crucial screening opportunities. So make sure that screening efforts are happening kind of across the board. We also know, as I mentioned before, that eating pathology is a spectrum. It's not a simple black or white, either you have anorexia nervosa or you don't. There are many ways that people can be on this eating pathology spectrum without meeting every single diagnostic criterion. And that doesn't mean that those individuals on that spectrum don't warrant clinical attention. Many times, somebody might fall just short of those diagnostic criteria, but be in very serious need of medical or psychiatric intervention. So it's important to keep in mind that this can happen across the spectrum. We also know that there are certain marginalized populations who really are at risk for the development of eating disorders. So as I touched on briefly before, individuals in higher weight bodies are often missing from these screening opportunities because people in clinical practices may not recognize that they're at risk for having these symptoms. So they often go undetected, they often go without treatment and continue to get more sick. We also know that racial, ethnic, sexual, and gender minorities are at risk for eating disorders for a whole myriad of reasons, things that are, I think, beyond the scope of this particular presentation. But it's worth noting that these populations certainly can have eating disorders that are very serious in nature. Some really interesting research that came out recently from Carolyn Becker and her colleagues that I've also have referenced on the last slide found that food insecurity is a risk factor for the onset of eating disorders. Many of you here on this webinar may be treating individuals in rural areas or underserved areas, and those individuals may experience food insecurity at some point in their lives. So it's important to recognize that these individuals are also at risk for eating disorders, even though in the past we may not have immediately assumed that they would be at risk. In terms of weight and how that might present with eating disorders in your practice, I wanted to have Dr. Metz spend a little bit of time about what you might be looking for in terms of a patient coming to your clinic. So Dr. Metz, I wonder if you could walk us through a little bit about weight and eating disorder presentation.
Yes, thank you, Dr. Pete. So I'm going to focus on what providers might see in terms of weight and the presentation of eating disorders in the primary care setting. And as discussed by Dr. Pete in previous slides, we know that eating disorders present in individuals of all body sizes. And some of these individuals, when they come into your office, may present with weight loss, some with weight gain, or some with fluctuations of weight up and down, and some may have no change in their weight. Though all of these presentations can be associated with significant eating disorder behaviors and complications. In addition, weight suppression is a very important marker of an eating disorder. And weight suppression is defined as the difference between the highest body weight and the body weight at presentation. So there are multiple studies showing us the clinical significance of weight suppression as an independent predictor of the severity of eating disorders, treatment outcomes, and medical complications. And these associations are independent of the body weight at presentation. So for instance, onset of amenorrhea and anorexia nervosa has been independently associated with weight suppression and can occur at normal or higher weights in the setting of weight suppression. So in order to increase recognition of eating disorders in the primary care setting, it can be helpful to begin to think in terms of weight suppression in addition to that presenting weight or BMI. And then to touch a bit on what we might see in children and adolescents. So in this population, who we expect to be growing in height and weight, we may not see weight loss, but we may see a lack of weight gain or a lack of height growth as a sign of an eating disorder. It's important to note in particular that children normally gain on average 30 to 40 pounds during the 4 years around puberty. So in this age group, we're looking for signs that an adolescent has dropped off their growth curve on weight or height as a potential indication of an eating disorder. Again, this is irrespective of starting or presenting weight. And then lastly, as we continue to challenge the stereotypes of eating disorders, it is important to recognize that individuals of all body sizes can present with all different types of disordered eating behaviors. So restrictive eating, binge eating, purging, excessive exercise, and other behaviors each occur across a diversity of body sizes and can be associated with similar eating disorder cognitions and medical complications irrespective of body size.
Great. Thank you so much, Dr. Metz. So you might be thinking a little bit now about, okay, now we know the diagnoses, we know some of the warning signs and symptoms and how some of this might present in various patients. So you might have this idea of, well, what causes some of these eating disorders? What might make some of this come about? And that certainly could be an entire presentation in and of itself. But what I'd like to just briefly touch on here is the idea that eating disorders tend to be thought of as a biopsychosocial model, so that there's a complex interplay between biology, psychology, and then social or environmental stressors. So as one of the truths stated, I believe it was truth 8, genes alone do not determine who will be affected by an eating disorder. So although we've had some recent advancements in terms of identifying some of the first genetic loci associated with anorexia nervosa, that alone does not help us understand who will develop an eating disorder. We know that other things like traumatic events, or maybe a deficit in coping skills, or maybe cultural factors or media messages about beauty might come together to make make someone vulnerable to an eating disorder overall. Again, this slide is a gross overgeneralization of the decades of research that have been done in terms of eating disorder etiology, but I wanted to just briefly touch on this to indicate that there is no single path to the development of an eating disorder. I'd like to just kind of reorient us briefly. We're now moving on to our second goal, which is to identify screening measures and practices to detect eating disorders in your practice. Before launching into some of the specifics, I'd like to just briefly go over a little bit about why early detection is so important and why we're hoping that those of you who are on the front lines will be interested in screening for some of these conditions. So first, unlike some of the other conditions that your patients might come to you for, things like, the flu, or maybe it's a rash, or for those of you in a mental health care setting, maybe it's anxiety or depression, many patients who have eating disorders won't directly address that during a visit with you. So I'm just going to use the flu as an example. When folks have the flu, they'll come to the primary care office and say, listen, I'm not feeling well, I've got a fever, I'm feeling nauseous, I've got the shakes, or I'm sweating, here's what's going on. Someone with an eating disorder is unlikely to lay out all of those symptoms for you in a primary care visit because they might be ashamed of their symptoms or what's going on. So they may not actually present directly for eating disorders care. So that's part of why these screening measures can be really important in terms of spearheading that conversation with the patient. The other thing that's really important and unique about the primary care relationship in particular, or even general mental health clinics, is that oftentimes within primary care, you are seeing these patients regularly throughout the year and for many years at a time. So you have an existing relationship that you can leverage to have some of these tough discussions if you're concerned about eating disorder symptoms. And as with all things and almost all psychiatric and medical illnesses, we know that an early diagnosis and treatment tends to lead to a better prognosis. So the earlier we can catch these folks, the better that tends to be. So with regard to specific screening measures, I'd like to go over 4 different measures that you might be able to use easily within your practice. So the first is the SCOFF. And the SCOFF is an acronym for the 5 questions that you see here. Because you have access to the slides both now and later, I'm not going to read all the questions, but essentially these give you an overview of the different types of questions that are sensitive to picking up eating disorder symptoms in a general population. A positive screen would be indicated if a patient responds yes to 2 or more of these 5 questions. This has been well validated for many years throughout the literature in various settings, including primary care, college counseling centers, general mental health clinics, so this has been widely used. And there was actually an eating disorder screen that was developed specifically for primary care. And again, you can see that there are 5 questions, and if a patient responds yes to 2 or more of these questions, it would be considered a positive screen. And as you're reading these over, you can see that, again, these are designed to be kind of high-level questions that would tap into several different eating disorder symptom clusters. You might see that there are 2 questions that have asterisks, number 1 and number 3. I've highlighted these because in the validation study for this particular screen, which is also referenced in the reference slide, these 2 questions were found to be the most sensitive in terms of picking up on eating disorder pathology. So for those of you who might be in very busy clinic settings, who might not even have the bandwidth to ask all 5 questions, these 2 questions, number 1 and number 3, might give you the most bang for your buck. There's also another screen that was developed more recently called the Screen for Disordered Eating, and this was actually validated within a VA, so we're talking specifically within a veterans population. However, this was through a primary care clinic. So again, you can see that there are 5 questions, and just like the other screening measures, 2 or more yes responses indicate a positive screen. Again, these are designed to be kind of high-level questions that tap into several different symptom clusters, and these can be used pretty easily, whether it's on paper, on a tablet, whatever might be feasible for your clinic. Lastly, I wanted to present the National Eating Disorders Association online screener. So NEDA developed an online screening tool with some of the researchers in the field to kind of be a self-guided tool for patients, family, friends, anyone to really take. So this is a web link that is provided later in the slides that someone can access. Maybe it's there in your clinic. Maybe you ask them to take it in the privacy of their own home, and it will walk them through a series of questions to kind of help them understand how their relationship with food or their body might be problematic. And this is a screener that is free and accessible to anyone who might come across it. So in terms of who should be screened, for those of us who are in eating disorders, we're biased. Of course, we're going to say we think everyone should be screened, but I thought I might highlight a few different populations for the benefit of this audience. So certainly adolescents are a population that should be screened. We know in general that that is an exceedingly high time of risk for the onset of eating disorders, irrespective of the type of eating disorder. So the age range that you see there is not a hard and fast rule, but that's just to include some of our college-age students who may legally be adults, but aren't quite there yet in terms of maybe some of their developmental responsibilities. We also know that patients in key transition periods should also be screened. So what do I mean by key transition periods? So that might be things like the transition from high school to college, the transition into your first full-time job. Maybe it's your first pregnancy and all the body changes that are happening there. These are all key transition periods that might be periods of increased stress, where screening for an eating disorder would be particularly salient. We also know that patients with specific medical morbidities are at higher risk for the development of eating disorders, things like polycystic ovarian syndrome, diabetes, both type 1 and type 2, and various gastrointestinal complaints. There tends to be a variety of GI complaints that overlap between functional GI disorders and eating disorders, so this patient population tends to overlap. We also know that athletes should be screened. Many of you in here are familiar with that, this idea that there are certain aesthetic sports that have a high emphasis on physique that might place somebody at risk for an eating disorder. We also know that patients with a family history of eating disorders are also at greater risk and should be screened. One of the points that Dr. Metz and I have made several times at this point is that patients seeking help for weight loss should also be screened for eating disorders, given that we know that anyone with a history of dieting is at risk for the onset of an eating disorder. And then, as I mentioned briefly, veterans are those that should also be screened, given that they are at a high risk from a past history of traumatic events, a history of a variety of medical illnesses. In general, we found that they are a population at risk. So with that, I'd like to bring us to our third goal, in which Dr. Metz is going to spend some more time speaking in depth about how you might manage eating disorders in primary care.
Okay, so eating disorders can have many varied presenting symptoms and complications, and can often masquerade as other health conditions. So we're going to briefly discuss some of the more common presenting symptoms and complications that we may see in the primary care setting. And as Dr. Pete mentioned earlier, patients aren't always going to walk into your office and say they have an eating disorder. So it's really important to have eating disorders on your radar as you're seeing patients with some of these symptoms and complications. So first, fatigue and malaise. Of course, these are very vague and nonspecific symptoms, but they really can be due to different complications of eating disorders, including vitamin deficiencies, hypoglycemia, dehydration, or electrolyte abnormalities, for instance. Temperature dysregulation can occur in the setting of eating disorders, so some individuals can present with cold or heat intolerance, which can be related to hypothalamic dysregulation. Hypothermia can occur in severe cases of anorexia nervosa. Some patients may present with dizziness or a syncope, which can be due to orthostatic hypotension, and this can, of course, be related to dehydration in the setting of restriction or purging, and sometimes can be related to venous pooling that occurs in the extremities in the setting of severe malnutrition. Bradycardia is also a common presenting symptom or finding, and this is due to increased vagal tone and the body's energy conservation in the setting of starvation. Electrolyte abnormalities may also occur. There are various electrolyte abnormalities that we see. These are just some of the more common ones. So hypokalemia can occur due to self-induced vomiting, laxative abuse, or diuretic abuse. Hyponatremia can occur due to dehydration, or in some cases, excessive water intake, or what we call water loading prior to an appointment. And then ketonuria can be a sign of significant malnutrition. In terms of endocrine signs and symptoms, amenorrhea can occur, and this occurs due to hypothalamic dysfunction, and of note should never be considered normal, even in athletes, as it does represent an underfueling of exercise in these folks. Osteoporosis can also occur due to this hypothalamic dysfunction, as well as concurrent vitamin deficiencies, and some patients may present with stress fractures. And then one other point that's not mentioned on this slide, but important to bring up, is hypoglycemia, which of course is a worrisome sign of malnutrition, and also hypo or hyperglycemia that can occur in individuals with diabetes. So a few other symptoms and complications. GI complaints are very common presenting symptoms of eating disorders. So some of the things you may see in your office might include constipation or IBS symptoms such as alternating diarrhea and constipation. Heartburn can occur in the setting of self-induced vomiting. And some patients may present with bloating or nausea in the setting of gastroparesis. Hematologic complications can occur, including anemia, leukopenia, and occasionally thrombocytopenia. And these findings can be due to bone marrow suppression in the setting of malnutrition, as well as vitamin deficiencies. So vitamin deficiencies in particular that you might see in the setting of eating disorders may include iron, folic acid, B12 or vitamin D deficiencies, and occasionally thiamine or zinc deficiencies as well. And then cognitive symptoms are also common. Some patients may come in complaining of trouble with their memory or poor concentration or focus in the setting of malnutrition. And then lastly, psychiatric comorbidities are very common. So some individuals may present with anxiety or depression symptoms, which could be due secondary to their eating disorder or may be a comorbid condition. Okay, so once you have a patient in your office who you think may have an eating disorder, we're going to talk a little bit more about the medical assessment of these individuals. So, of course, checking standard vitals is important. So checking blood pressure and heart rate, looking for hypotension, bradycardia or tachycardia. Checking a temperature is also important to look for hypothermia in some severe cases, and assessing for a slow respiratory rate as well. And just to focus a little bit more on checking weights. So when checking weights, we recommend checking blind weights, which means that you have the patient step on the scale backwards and not tell them the weight, or have a scale in your office that has a screen that can be pulled away from the patient. So we know that seeing that number for a patient can trigger an increase in eating disorder thoughts or behaviors, no matter whether that number is going up, going down, or staying the same. So we really encourage our patients to stop weighing themselves at home and to really let their providers track their weights if needed from a clinical standpoint. We also recommend checking weights in a gown in order to have an accurate and consistent weight at each visit, and to check that weight in a private, safe space inside an exam room, so that can make the patient feel more comfortable. And then one point about the health record system, we do recommend entering the weight in a place in the health record system that a patient would not be able to see, so that would not print out on their after visit summary or be visible to them on the portal, which could of course be triggering. So a couple other points about vital signs. So orthostatic vital signs are an important part of the medical assessment of eating disorders. As many of you may know, the definition of orthostatic vital signs is the comparison of the blood pressure and heart rate after lying down for 5 minutes to the blood pressure and heart rate within 2 to 5 minutes of standing up. And orthostatic hypotension is defined as a 20-point or more decrease in systolic blood pressure and or a 10-point or more decrease in diastolic blood pressure. And then orthostatic tachycardia is defined as an increase in heart rate by more than 20 points. And those, of course, would be concerning signs. And then lastly, in terms of vitals, the heart rate walk test. So this is a useful test when a patient presents with bradycardia, particularly in those who exercise frequently or are athletes, as you may have patients who attribute their bradycardia to their conditioning due to their exercise. So what you can do is check the patient's heart rate at rest and then check their heart rate after they walk up and down the hall in your office a couple times. And what you will see is that in a conditioned athletic heart, in a patient who is well nourished and fueling their exercise, they will have little to no change in their slow heart rate with this small exertion. But a patient who is malnourished will likely have a significant increase in their heart rate due to the heart's need to work harder with this malnutrition, deconditioning, and weakening of muscle, including weakening of the heart muscle. So in terms of the exam, there are many possible exam findings, of course, in the setting of eating disorders. These are some of the things you might see. You may see lanugo, which is the fine downy hair, often on the face, arms, or back in the setting of severe malnutrition. You may see hair loss or dry skin. Petechiae can occur, though this is rare in the setting of thrombocytopenia. In terms of the head and neck exam, it's important to assess salivary glands. You may see enlarged parotid and submandibular glands in the setting of self-induced vomiting. Assessing mucous membranes can help when you're looking at hydration status. And assessing dentition is important. You may see erosion of dental enamel in individuals who are experiencing self-induced vomiting. The cardiovascular exam, also important, of course. You may hear heart murmurs. One of the more common findings in the setting of anorexia nervosa is mitral valve prolapse, so important to listen for that. Arrhythmias can occur, so you may hear ectopic beats due to electrolyte abnormalities, or of course tachycardia or bradycardia. Assessing for edema is important. This sometimes can occur due to fluctuating purging behavior, so we sometimes see it when an individual abruptly stops a purging behavior. There may be some edema present. And then checking pulses and looking for something called acrocyanosis, which is the bluish discoloration of the extremities due to vasoconstriction in the setting of malnutrition. Assessing respiratory status is important as well. On the abdominal exam, you may hear hypoactive bowel sounds or distension, which can be due to slow gut function or constipation. There may be some tenderness on exam and rarely hepatosplenomegaly. And then on neurologic exam, in very severe cases of malnutrition, you may see weakness, decreased sensation, abnormal reflexes, or ataxia. Again, this occurs rarely in severe cases. And one last point about the exam is that an exam may actually be completely normal. So important to keep that in mind, that it can be normal even in the setting of severe eating disorders. So upon further assessment here with labs, these are some of the labs you may consider when medically assessing an individual with an eating disorder. So of course, the CBC to look for anemia and leukopenia. You should check electrolytes and renal function, including the magnesium and phosphorus levels. Liver function tests should be checked. They can be elevated due to malnutrition or sometimes elevated in the setting of refeeding. Amylase and lipase can be elevated sometimes in the setting of purging, or could be elevated in the setting of malnutrition. Thyroid function tests are also helpful pieces of information, so it's common to see a low free T3, or what we call the euthyroid sick pattern in the setting of malnutrition, which is due to the hypothalamic pituitary changes that is used by the body in order to decrease metabolism in the setting of starvation. A UA can be checked to look for ketones. A urine pregnancy test should be checked in the setting of amenorrhea or oligomenorrhea, and a urine drug tox if concerned about alcohol or drug use, or when required by treatment centers. A CK, which is a creatine kinase muscle enzyme, can be checked in individuals with muscle aches, and this is assessing for any risk of rhabdomyolysis. And then, of course, we have vitamin and mineral levels listed here that should be checked to further assess malnutrition. And lastly, hormone levels, so FSH, LH, and estradiol or testosterone to assess for that hypothalamic dysfunction. And again, as a last point about labs may also be very normal even in the setting of severe behaviors and malnutrition with anorexia nervosa. So a few more tests that may be considered. An EKG is often obtained in the medical assessment of eating disorders, again assessing for arrhythmias, bradycardia, and also looking for prolonged QT. An echocardiogram is sometimes obtained based on symptoms, exam findings such as murmurs or abnormal EKG findings. X-ray imaging, including abdominal imaging or bone imaging, may be needed based on symptoms or complications. And then lastly, a bone density test. So this is a very important test to obtain in individuals who have had anorexia nervosa for 6 months or more. or have amenorrhea or low testosterone in men, or present with a stress fracture. And this test assesses for osteoporosis. And one important point about this test is that we typically look at Z-scores in premenopausal individuals to assess for osteoporosis rather than the T-scores that we see in postmenopausal women. And you're looking for a Z-score that is less than minus 2.0 as being abnormal. And I'm going to pass this back to Dr. Pete.
So now that we've had a chance to spend a little time identifying what eating disorders are, what the warning signs and symptoms are, how you might screen for them, and then also how you might manage some of that in a primary care setting, we thought we might give some concrete examples of how you might approach a patient if you do have some of these concerns. And then subsequently, we'll also have some things that we are encouraging you to avoid. Again, I know that all of you have these slides in front of you, so I'm not going to read these verbatim, but essentially, we're encouraging folks to be thoughtful about how they approach patients if you have concerns. So you want to be direct in expressing some of your concerns and why those particular concerns are worrisome to you. So as a primary care provider or even a general mental health provider, you might know this patient particularly well. So you might know how much of this is a change from baseline, and being able to talk about that authoritatively and why these things are concerning to you. You can talk a little bit about why these symptoms are so serious and why they're of concern to you medically and psychiatrically. Many times people who engage in eating disorder symptoms or behaviors are actually unaware of how dangerous things like that can be in terms of their physical health. So being a healthcare provider puts you in a unique position to be able to explain some of that to your patients. In terms of the don'ts of approaching patients, I'm hoping that a lot of this will be very obvious and straightforward to you all, but we would encourage that you don't have these discussions in an open area with others around. So avoid having these discussions in a waiting room or in the hallway on the way out to check out. And we'd encourage you to not give simple solutions. Things like, you just need to eat more, or you just need to stop binge eating, or whatever it might be. Again, these do's and don'ts are not an exhaustive list. There's designed to just kind of be a guide for how you might have some of these discussions, since we know that approaching individuals about their eating disorder can be a challenging thing to do. I also want to touch very briefly on treatment, and I will say, as full disclosure, a lot of this is going to be kind of a precursor to the second webinar that we'll be offering in the fall. I believe there'll be some additional information about that at the close of this presentation. But today is really just meant to give you a very broad overview of what treatment might be, how that tends to work for individuals with eating disorders, as kind of a primer for the second webinar. So in terms of treatment, we know that overall eating disorders treatment is interdisciplinary. There tends to be a psychologist or a therapist of some kind, a dietitian, a medical provider, and oftentimes a psychiatrist. So the four of those individuals usually have expertise in eating disorders, particularly the therapist and the dietitian, because they're the ones that are going to be doing a lot of sort of the heavy hitting with the interventions themselves. So treatment usually is interdisciplinary in nature and can involve a variety of different levels of care. So there's everything from the highest level of care, which would be inpatient hospitalization, and this is typically for folks who are medically unstable, have acute needs that really aren't safe to be treated as an outpatient, all the way down through the next step, which would be residential. Partial hospitalization or day treatment tends to be things like Monday through Friday, roughly 8 to 5 or earlier, so that they're having a significant amount of treatment, but maybe not quite moving down to intensive outpatient, which is the next step down, which is maybe doing your therapy and your nutrition visits a couple of times per week. And then the lowest level of care that we would talk about would be outpatient, which is kind of the stereotypical, you might come to see your therapist and your dietitian about once a week. Again, the eating disorder specialists are the ones that typically are determining what level of care is most appropriate. And we'll talk more about that in our upcoming webinar in the fall. But this is just to give you a broad overview of the types of care that might be available to your patients with eating disorders. In terms of the types of interventions, with eating disorders, we know that the primary interventions are really going to be focused on the psychological. So we know that across eating disorder diagnoses, cognitive behavioral therapy, which many of you here are likely familiar with, is a frontline treatment for eating disorders across the spectrum. So in this treatment, individuals are learning to identify patterns, negative thoughts, and underlying functions of their eating disorder behavior. They're learning coping skills, they're learning alternative strategies. Within family-based therapy, the parents or the guardians, typically of adolescents or children, are actually the ones that deliver the treatment. So instead of the adult patient being responsible for developing a meal plan, going grocery shopping, those sorts of things, the parents are really delivering that for children and adolescents. There are a few pharmacotherapy interventions that are used for the treatment of eating disorders. Typically, these are used to treat the comorbid psychiatric conditions that Dr. Metz had indicated, things like anxiety and depression. But there are some pharmacological interventions specific for binge eating disorder that will be used to treat the symptoms themselves. So as of right now, the only on-label FDA-approved medication for the treatment of an eating disorder is for binge eating disorder specifically, and that's lisdexamfetamine. If you do have a patient who you suspect has an eating disorder, then you have a conversation, you're able to discuss the extent to which these symptoms are concerning to you. What might you do then? So I've screened them, we've had a discussion, now what? Essentially, what we'd like to encourage you to do is provide referrals, especially if that can be done locally, given that many patients will have difficulty traveling or finding a way to pay for that treatment if it's out of state. So I provided a web link here called Find ED Help, so that you or your patients can go to this searchable engine to determine, based on their location and their insurance, what type of treatment might be available to them. Again, one caveat here is that the National Center of Excellence for Eating Disorders has not vetted every single treatment center or provider on this list. That's sort of beyond the scope of what we're doing with our center, but this is just designed to kind of give you a place to go if you're looking for referrals for your patients. And again, keep in mind that even if you do refer a patient for treatment, your role as the provider doesn't end there. There may need to be consistent, ongoing communication between you and the eating disorder program, especially if you're in primary care, so that you can continue to monitor physical health as needed. So with that, I'd like to present the overall references that we have for the slides. I know that's terribly small print, but you'll have access to the slides if you'd like to look at them later. And at this time, what I'd like to do is turn it back over to Lillian, who is going to post one last polling question for us. So before we get to the Q&A that all of you will be able to present to us, I'd like to ask one further question of all of the audience members. So Lillian's going to pull up the third polling question, which is just for us to get a sense of how much you've learned as a result of attending this particular webinar. So again, just read the question and use the appropriate radio button in order to help us craft the best experience possible as you're attending these types of webinars. Again, I'll give everyone a few moments to respond, and then essentially what we'll do is have the opportunity for questions from the audience that both Dr. Metz and I can respond to. So again, we will give everyone just a few more seconds here to respond, and then we'll move forward with the Q&A portion from you all. I'm going to give everyone another 10 or 15 seconds here, and then we'll move on. Thank you so much for your participation in this. This is really helpful for us. All right, Lillian, if you'd like to go ahead and close down that poll, we'll go ahead and open it up to questions that the audience might have.
We're going first to Lillian for if there are any questions in the CDC auditorium.
Speak up.
Oh, okay. I just have a question regarding if there's any research so far on the effects of eating disorders on gut bacteria and the microbiome, because I think it's an interesting topic, and I know there's ongoing research, but I'm not sure if any findings have been made regarding, permanent damage or otherwise, implications or effects of an eating disorder, specifically anorexia. So.
Thank you.
Sure. So what I'd like to do is just briefly...
Or Dr. Matt. Yeah.
Yes, so this is Dr. Pete. I'm going to just briefly reiterate the question in case folks couldn't hear it. The question was about whether or not there's been any research done on the microbiome and eating disorders, and specifically looking at anorexia nervosa and the gut microbiome. And my short answer to that question is yes, there has been some preliminary research looking into how the gut microbiome is altered in anorexia nervosa, and that's actually being done here at UNC. So for those that are interested, Dr. Cynthia Bulick and Dr. Ian Carroll are spearheading some of these research initiatives. And essentially what we're finding is that if you are malnourished, certainly it has negative impact on your gut microbiome. The good news is that through refeeding after an inpatient trial, some of that gut microbiome starts to, for lack of a better term, kind of level out. So this isn't necessarily irreparable damage, but we do know that it is altered significantly, especially during low weight anorexia nervosa.
Thank you. Did that answer your question?
Oh, yeah, thank you. I'm actually a student at UNC, so I saw some information about that trial. So yeah, that's really interesting. Thank you very much.
Thank you. Lillian, are there any other questions at your site?
I have one question about public health. Is that okay? We are CDC, right?
Right.
So has there been any effort collaborating with public health to prevent this? Because it seems like we will have a lot of partners that we could engage in.
Yes, so this is Dr. Pete. There have been substantial efforts to work with public health in terms of reducing the impact of eating disorders, both in sort of across prevention settings, so whether that's primary, secondary, or tertiary. I think the definitive experts on public health and eating disorders is the STRIPED, S-T-R-I-P as in Peter, E-D organization based out of Harvard. Dr. Bryn Austin, who's actually now the current president of the Academy for Eating Disorders, runs STRIPED, and they have done tireless work to help reduce the overall impact of eating disorders on a public health scale.
Thank you very much.
I think that's all from our side.
Okay, I will read a question from the Q&A box. I think there was one ahead of that. Megan asks, is there a link between the frequency of self-induced vomiting and vagal nerve transition?
Dr. Metz, I'll let you cover that one.
So that's a good question. I am actually not familiar with any research looking at this question in particular. So I don't have any information to provide now, but something that we could look into.
Thank you. And then Steph, there was one before that. Okay. Jeremy asks, is amylase testing a reliable indicator of purging behavior?
That's another good question. And no, it is not a great indicator of purging behavior. It can sometimes be elevated with in the setting of purging, but really cannot be used to determine if someone is purging or not. I am not sure about the details of the sensitivity and specificity looking at that question, but it's generally considered not to be a great test to assess whether an individual is purging.
you. And Katie has a question. What frequency of screening, what
frequency of screening do you suggest in a college health clinic?
Sure, that's a great question. So Katie, I think what I would say is that we would advocate that anyone coming in for their first appointment in a college health clinic should be screened for an eating disorder. So in the same way that you might have intake questions that patients fill out prior to their first visit in the primary care clinic, for example, that some of these screener questions that we've covered today might be included as a part of that paperwork. And then I think as necessary, in terms of clinical judgment, if you're seeing any of the warning signs or symptoms, or you're noticing any of the changes in labs that Dr. Metz had discussed, that might be an indicator to give the screener again or to have a discussion with that patient. I'm not sure if Dr. Metz has anything else to add there, but that would be my primary recommendation.
This is Dr. Metz. Yeah, I would agree with that. So I definitely recommend with any initial patient paperwork to include the screening questions, and also would consider adding them to annual paperwork. So when a patient comes back for their annual checkup, which is what we do in our office, and definitely, as Dr. Pete mentioned, when patients present with symptoms that could be markers of eating disorders.
Thank you very much. MCCS, we have a question regarding specific resources regarding screening of risk in male children. Male athletes, sorry.
So for the person asking this question, there are actually some really good resources available through the NCAA. They actually have a whole module talking about eating disorders in athletes that I think could be applicable. I don't know that it gets to be gender or sex specific, but it is certainly athlete specific. So I would encourage you to take a look at the information that's provided through the NCAA. I would also say that there is no reason that some of the screening questions that we've discussed in this presentation couldn't be used for male athletes. I think that these are broad enough and sensitive enough to be able to pick up any kind of eating pathology there. Again, I know that Dr. Metz has worked with athletes in her practice, so if you have something else you'd like to add there, please go ahead and do so.
I don't have anything else to add. I agree with using the standard screening questionnaires for this population as well.
Thank you. Have there been any collaboration efforts within public schools since adolescents are the most at risk?
This is Dr. Pete. So I would say that yes, there have been several collaborative efforts, again, through organizations like Striped out of Harvard, also the Academy for Eating Disorders, the National Eating Disorders Association. All of them have done work either highlighting some of the concerns within private schools, public schools, private schools. There have been several efforts in terms of trying to get screeners into some of the schools. The challenge, of course, is that all of this is going to vary based on the state, based on the school district, based on the individual school board at times. So I think the person asking this question is absolutely right. This is an area of risk, and getting more school professionals involved is crucial. And part of what the National Center of Excellence is going to be doing is providing specific resources for those that work in school settings. So if you're a school counselor or a school nurse, or you're a teacher, depending on your role, what are some of the resources or trainings that we can offer in that regard?
Thank you very much. Jamie also asked, do you have any recommendations in the community setting of how to check in with adults about their eating disorder without triggering?
Dr. Metz, do you want to take that one?
So the question is, let's see, how to check in with adults about their eating disorder in the community. So I think really just making sure that we are being non-judgmental when we're asking questions, and really showing support and being non-judgmental when we're asking patients about their symptoms.
What about providing other indications of purging behaviors based on labs? From Joan Shannon.
So indications of purging behaviors based on labs. So the things to look for are electrolyte abnormalities, so low potassium, sometimes a low sodium, sometimes elevated kidney tests could occur. But sometimes all of these labs can be normal, and the body has an amazing ability to compensate for these behaviors. And so the labs are not always normal, but those would be the ones to look out for. And also checking a urinalysis for signs of dehydration or ketones. That could be a sign of malnutrition.
Thank you, Dr. Metz. Jeremy also asks, is there a length of time with an eating disorder in gastroparesis? I'm sorry, I lost. It looks like irreparable.
So gastroparesis, which is an impairment of the function of the stomach in the setting of malnutrition or binging and purging behaviors, that can be a chronic symptom. And I don't have a great answer for that question. Sometimes the gastrointestinal side effects of eating disorders, including gastroparesis, can go on for a while, even after behaviors have improved. But we do generally see gradual improvement, over months' time in some of these GI complications.
Thank you very much. Judith Wembui Preston asks, are there major differences in how binge eating disorder shows up in white versus black populations?
That's a great question. Thanks so much for asking. I think that, again, as we mentioned it earlier in the presentation, we know that eating disorders don't discriminate based on race or ethnicity. However, the symptoms may present differently, or the context may be different depending on what part of the population that you're working with. So for example, depending on the population, again, and this may not be specific to the African American population, but sometimes there is greater reticence to step forward and talk about these concerns. Sometimes eating disorder symptoms like binge eating or even that sense of loss of control might even be culturally sanctioned, or might just simply not be identified necessarily as a problem within a particular community because the culture hasn't identified it as such, or doesn't typically identify it as such. So I think oftentimes the symptoms may look very similar in various portions of the community, but how they get discussed or how readily they are identified could vary depending on that community.
Thank you very much. We'll take another question from Catherine K. This is a question for Dr. Metz. I noticed in your bio a mention of the health at every size approach within your practice. I work with a lot of clients who are clinically obese and are continuously stigmatized by healthcare providers because of their weight, leading to disordered relationships with food and eating. How do we work with patients, clients in larger bodies on developing a healthy relationship with food when our healthcare system is so fixated on weight, BMI, and other indicators? Thank you.
Thank you. That's another very good question, and a complicated one, but there are ways that we can start, in a practice by practice level to think about doing things a little bit differently, and really think about providing, non-judgmental care when it comes to weight and health. And so one of the things that we do at our practice is that we don't weigh our patients at their visits unless there is a clinical indication or unless they have an eating disorder from which they are actively recovering. So limiting weight checks unless it's actually indicated can be helpful, but really working to reduce the stigma of body size, which can lead to potentially lead to improved health outcomes, since we know that weight stigma, which Dr. Pete mentioned earlier in the presentation, is associated with negative health outcomes. And so by beginning to reduce some of that stigma, we can really begin to help individuals with their long-term health. And so what we focus on is on behaviors and health goals that each individual patient may have. We do, again, talk about behaviors and refer to dietitians who might talk with patients about intuitive eating, but really try to take away that weight loss goal from the work that we do with our patients. There's also...
Thank you.
I'm just going to suggest there are some resources for that, including the Association for Size, Diversity, and Health website.
Thank you very much. I'm afraid we have run out of time now to finish the questions, but if you could please put your email address in the Q&A box, we'll see if we can get a response from the speakers, and Dr. Pete has provided her email address as well. Lynn has some closing remarks, and then I will just remind us and thank our speakers very, very much. We hope that you will seek continuing education units. For those of you who joined early and didn't see the instructions are in the download pop. We will leave this up so you can upload the file and see how to get the continuing education. Lillian?
Yeah, well, thank you. On behalf of CDC Preventive Medicine Residency and Fellowship, I thank the speakers for a very interesting and informative presentation and all participants' time and interest. So please follow up with the second session on this topic on September 11, 1 o'clock. And also tomorrow at 2:30, it will be the CDC Preventive Medicine Residencies grand round. So we welcome you too at 2:30. It will be the presentation by the resident and fellow, and they will talk about Atlanta's Strong for Life initiative addressing childhood obesity, and also Fulton County Health Department's experience in preparing for the Super Bowl that just happened in Atlanta recently. So, and then again, thank you everyone for your time, and we close.
Thank you very much. We're now closing the webinar. And do we have us all together for a little debriefing?
Should we call back for that?